This illustration shows the two main coronary arteries that arise from the aortic sinus. Remember that the first oxygenated blood that comes out of the ventricle is going directly to the heart itself. And so if you notice in this drawing or this depiction, what you see is that the right side comes off fairly easily and supplies the blood flow to the right side. The left side, if you notice, it actually flows in between the pulmonary vein and the aorta, and then comes down and supplies the lower portion and the back side of the heart, which is primarily the left ventricle. We are looking at coronary artery disease, or CAD. The primary cause is going to be atherosclerotic blocks of the coronary arteries. There's two types of atherosclerosis: the fixed or the stable plaques that block blood flow, and the vulnerable or unstable plaques that can rupture and lead to thrombus formation. I wanted to show you these illustrations because this one at the bottom on the left is looking down a blood vessel, and you can see how with this blockage there, it's going to be really easy with this uneven and rough surface for the platelets to want to aggregate and stay with that atherosclerotic area rather than flowing right on through. The other thing that's going to make this more prone to a thrombus formation is the fact that it doesn't have that nice laminar flow that just flows so evenly and smoothly. It's going to hit this narrowed area, and then so the area behind it is going to be backed up somewhat, and then the area after the atherosclerotic area is going to have a lot of turbulence in it, which will mean that there's even more chances for a thrombus to form. If you look at the illustration on the right, it shows the normal artery and then the stable plaque versus the unstable plaque. The plaques tend to form in the left anterior descending or the left circumflex arteries. In some cases, though, the entire right artery is involved. When we're looking at acute coronary syndromes, the first thing that we're looking at is ischemia, and that's remember, the definition of ischemia is decreased oxygenation to the tissues, and so with that we may have angina, we may actually have a heart attack, it may cause cardiac arrhythmias, it can cause conduction deficits. If that continues and we start getting necrotic areas because of that continued amount of ischemia, we can have heart failure and sudden death. The ECG changes that we see are T-wave inversions, ST segment depression or elevations, and abnormal Q waves. And I'll show you some pictures of those with the next slide. The serum cardiac markers are really quite amazing. They are based on proteins that are released from necrotic heart cells. They include myoglobin, creatinine kinase, and troponin. Troponin has a high specificity for myocardial tissue, and they are the primary bioblockers for myocardial infarction. They begin to rise within 3 hours after the onset of an MI, and they remain elevated for 7 to 10 days afterwards. So it stays with this person for a long time. The CK, or the creatinine kinase, is an intracellular enzyme that's found in the muscle cells. CKMB is highly specific for an injury to cardiac muscle. The CKMB increases within 4 to 8 hours after injury, and it declines in 2 to 3 days. So it doesn't stay with the patient as long as the troponin levels do. But it may actually start to, and it shows up after the troponin levels do. The myoglobin is an oxygen-carrying protein that's similar to hemoglobin, and it's expressed in skeletal and cardiac muscle. It can be detected in the blood, or the higher levels can be detected in the blood within an hour after the myocardial cell death, and it peaks within 4 to 6 hours. However, the one thing about it is that it's not specific to the cardiac muscle because it's also found in the skeletal muscles. So like the others are very specific for an MI having happened, this could be caused by you going out and jogging too long and having a lot of lactic acid build up in your muscles. And so it just is not as specific, but yet we look at all three of these together to make a diagnosis of an MI. So this one may take a little more to explain than if we were sitting there side by side, since I don't have a way of pointing at things. But if you look at the middle example where it says normal, our first little lump there is the P wave. The Q is at the bottom of the next spike. Then the very top part of that spike is the R. Coming down at the bottom is the S. Then it comes up, levels out, and then we have the T wave. The ST segment starts with that bottom spike that goes below the baseline, and it ends at the end of that T wave. So if you look at the first picture, you can see how the ST is elevated above the baseline. So that's what we say when we have an ST elevation. The picture on the right-hand side, you can see that instead of coming back up to baseline like it should in a normal ECG, it remains below even as it starts to go into the T wave, and so we call that an ST depression. If we were looking at a T deflection, in other words, it's going below, basically we would just be seeing a T wave that looked kind of like the one on the right, except the T wave would be under the baseline as well. The unstable angina and the non-ST elevation myocardial infarction, or the NSTEMI, are not covered a great deal in your book. However, what we see with those is that there's usually no evidence of the serum markers for myocardial damage with the unstable angina. With the non-ST elevation myocardial infarction, or the NSTEMI, the pain occurs at rest or at minimal exertion, lasting more than 20 minutes if they don't treat it. Remember, if somebody is having unstable angina, they may be on a nitrate or a nitrite, and those cause vasodilation. And so that's what we mean when we say treated or untreated. If they're taking their nitroglycerin tablets, then we would say that they were treated. So if the person decides they're not going to take them, then it would take about 20 minutes for them to stop having this pain at rest or minimal exertion. Minimal exertion would be something like walking across the room. Or the pain is severe and it's described as frank pain and of a new onset. Usually we'd say it's of a new onset, that it's within a month that they've started having this pain. Or the pain is more severe, it's prolonged, or more frequent than previously experienced. With the NSTEMI, there are detectable serum markers of myocardial damage, and the degree of ST segment deviation from baseline is a really important measure of ischemia and an indication of prognosis as far as it going into a more serious STEMI event. As you do more clinical in your med-surg class, you'll probably start hearing people talk about STEMIs. There's a lot of STEMI protocols and STEMI trainings that are usually available at the hospitals. And especially if you go into the ED, you're going to hear them talk about the STEMI protocols. STEMI stands for ST elevation myocardial infarction. The pathological changes that happen with that are dependent on the size and the pattern, as far as the location and the extent of the occlusion, the amount of tissue that's supplied by that vessel. Think about that picture that we looked at with the first slide. You saw that how those arteries go around the vessel, and in some cases there's not a lot of collateral vessels supplying an area. So if you have an area where there's several vessels that supply that area, then you probably aren't going to have as much damage to that area as if you have an occlusion above one of the main part of those collateral vessels, so that there are no collateral vessels supplying the area. How long did the occlusion last? It's why these STEMI protocols are there, because we want to get medication into the patient as quickly as possible to reperfuse that area and get the oxygenation back to that part of the heart. What's the metabolic needs of the affected area? If we're looking at the blood supply to an atrium, it's not going to have as much metabolic demand as if we were looking at the left ventricle. The other things that we look at is the extent of collateral circulation. Like I was just saying, if it was one of the little collateral vessels, then there's another one that's probably close enough to supply that area. But if we're looking at the main artery coming to all of those little collateral vessels, then there's not going to be any collateral area there. Other factors can be the heart rate, the blood pressure, and the cardiac rhythm. How close to normal are they? Or is the heart acting very unstably? Do we have ventricular fibrillation? Or do we have a fairly normal sinus rhythm? Those are going to make a very big difference to how much damage and how much pathology is going on. So you'll often hear the phrase acute MI or STEMI. They're used interchangeably. And so when we start thinking about acute MI, we have to think about what's being damaged. A transmural infarct involves the full thickness of the ventricular wall. And this is what this picture is over here on the right-hand side. The subendocardial infarcts involve the inner 1/3 to 1/2 of the ventricular wall. Conversion of aerobic to anaerobic metabolism leads to inadequate energy production to sustain normal cardiac function. This is where we go back to that beginning part of pathophys when we were talking about the cell. Remember that when the cell is in an aerobic metabolism, it produces a lot of ATP, which is our energy packets for that cell. And when we go into anaerobic, we're not making nearly as much ATP. The heart cell has extremely high metabolic needs, and so if we don't have enough oxygen, then that cell is not going to get enough of those ATP packets to keep going. And that's why we end up seeing lots of contractile function within 60 seconds of the onset of the myocardial infarction. The cell changes develop within several minutes, although they are reversible if the blood flow has been able to be restored. The ischemic areas cease to function within a matter of minutes. And so if you think about that, that means that we're getting damage to those cells if they're not functioning. And that occurs within 40 minutes. Irreversible cell death occurs after 20 to 40 minutes of severe ischemia. So if you think about how long it normally takes somebody to realize that they're having a heart attack, and then call the EMTs, and then get transferred into a hospital, we've already hit that 20 to 40 minute period of time. But yet we still are getting really good results with getting the blood flow reestablished and being able to get some of this heart muscle back alive again. So reperfusion is the word that we use for reestablishment of blood flow. The way we do that is with fibrolytic therapy, and that's a medication that starts to break down the fibrin in that clot that is blocking off that artery. Revascularization procedures are things like heart caths, where we're able to go in and get a stent, or we balloon it open so that we can get blood flow reestablished in that area. We can only do that if it's if it's become very, very narrow, but it's not blocked, because obviously we don't want to push a clot farther into somebody. So the reperfusion can prevent necrosis. If we catch this when it's just ischemic but not necrotic, we can prevent the necrosis. We can improve the myocardial perfusion of the infarct zone. And this recovering area is often referred to as a stunned myocardium, because it hasn't had good oxygenation for however many minutes it's gone without it. And so it may take several days for it to recover from this stunned situation.
It started out like a totally normal day. Okay, move objection deadline to the third line after survey. Oh, honey, for when you always use the verb estar. What are you doing down there? Did you finish your breakfast?
Ow.
Whew. Don't hit your brother. Honey, you have to eat something. Here. Okay, 5 minutes to carpool. Where's my coffee?
You okay, Mom?
Oh, I'm fine. Sandwich orders. What do you want?
Almond butter and jelly.
Spaghetti.
You sure you're okay?
I'm fine, sweetie.
I am so late. Hey, buddy, how you doing? Hey, honey. You okay?
Yeah, I'm fine.
You sure?
Oh, yeah. Here.
Acai, my favorite. See you guys later.
Where are your shoes? Put your shoes back on, please. You know, go help your sister. We're going in 3 minutes. Oh my God, what am I doing? I forgot to cut off the crust. Voila. Shoes on, potty if you need it. Honey, get your sister. Okay, get her. Nobody move. I'm getting a dustpan. Oh.
Mom! I think you're having a heart attack.
Honey, do I look like the type of person who has a heart attack? I'm just gonna sit down. I'm totally fine. Don't forget to wear the high socks with the shin guards.
Forget about the shin guards, Mom.
Come on, Mrs. Underdog is not gonna wait. Whoa. Okay. 9, 1, 1. Hi, sorry to bother you. I think I might be having a little heart attack. Nothing really, just some nausea, tightening of the jaw, dizziness, shortness of breath, muscle pain, achiness, this terrible pressure in my chest. Oh, really? They can be here in how long? 2 minutes. Can you make it 10? I thought I had gas. Turns out I was having a heart attack. Heart disease is the #1 killer of American women. So now I take care of my heart and I tell the women in my life to do the same.
Sounds great, by the way.
That's nice, sweetie, but that's not my heart. That is. Make it your mission to save your life and the lives of the women you love. Find out more from the American Heart Association at goredforwomen.org.
The symptoms of a STEMI or acute myocardial infarction is chest pain, severe crushing, constriction, or in some cases it may be like really bad heartburn. Often there is substernal pain that radiates to the left arm, the neck, or the jaw. If you think about it, the sympathetic nervous system responses of GI distress, nausea, vomiting, tachycardia, and vasoconstriction goes right along with all of this, including anxiety, restlessness, and a feeling of impending doom. One thing to keep in mind is that women tend to have different symptoms than men, and as a result, women are more likely to die of a myocardial infarction than a man is. That's because when they come to the emergency room, they start talking about these vague pains that they're experiencing, and often the doctors do not pick up on the fact that these are symptoms that women experience with MIs that are different than men. Women usually will talk about being short of breath, having pressure or pain in the lower chest or the upper abdomen. They may talk about being dizzy, having lightheadedness, feeling like they're going to pass out, having upper back pressure, or extreme fatigue. Women will often chalk up these symptoms to less life-threatening conditions like acid reflux or maybe even normal normal aging. So if you think about if they're having back pressure instead of chest pressure, why a doctor might look at it and interpret it incorrectly. An early diagnosis is especially important because the earlier treatment is instituted, the greater chance is that they'll avoid ventricular fibrillation. The ventricular fibrillation tends to be the reason why most people die of an MI. The emergency room goals are to rapid evaluation so that they can start reperfusion therapy, getting a 12-lead ECG, continuous ECG monitoring to see any changes. Remember, we're looking for these ST elevations or depressions. We're also looking for that inverted T wave. Treatment regimen includes oxygen. We want to make sure that heart muscle gets as much oxygen as we possibly can so that it's not hypoxic, so that it's not having ischemia, so that as much of it as possible is perfused with good oxygen-rich blood. We want to give aspirin. Remember, aspirin will keep the platelets from aggregating. So in other words, it will prevent additional clot from forming. Nitrates like nitroglycerin will dilate the vessels, and that may open up that vessel just enough so that blood flow, although not perfect, is reestablished into that heart muscle. Morphine went through a little phase where people kind of thought that maybe it wasn't as effective as what they thought. But the reason that we give morphine with an MI is that pain activates the sympathetic nervous system, and that causes or aggravates the diaphoresis, the weakness, and the palpitations, and that increases cardiac workload. So we don't want to increase the workload at a time that the heart is most vulnerable because it doesn't have enough energy getting to it. So everything that we're doing is decreasing the heart's workload. I want to go back to oxygen a little bit too. Oxygen is also known to be a vasodilator. If you are hypoxic, you have vasoconstriction. So if I give you oxygen, that's going to help the vessels to relax and you'll get more blood flow through it. So everything that we're doing here is looking at opening up those blood vessels as much as we can to get the oxygen to the heart. Antiplatelet and anticoagulant therapy will be started as well. Beta-adrenergic blocking agents, or beta blockers, remember, and angiotensin converting enzyme inhibitors, or ACE inhibitors, will be started as well because they act as a heart protection. Fibrolytic therapy is also started to break up that clot that's already established. They often will go ahead and do a percutaneous coronary intervention if it's a UA or an NSTEMI, and if it shows that there are more than 2 or more vessels that are blocked, these patients will get in very quickly for a coronary artery bypass grafting, or we call that CABG. And you can see how each one of those letters of those words spell out CABG. And so if you're ever in the hospital and you hear, oh, he's going for a cabbage, that's what they're going for, not to go get something to eat. This is a video that shows a balloon angioplasty, and it also shows how the stenting is done, which is done more or less the same. I'm hoping that it's going to show for you with this video, but I don't know for sure if it will. But talk to me and I can send you the links if it doesn't show. So let's think about post-MI recovery. Think about the inflammatory process and also think about the healing process when there's been an injury to the tissue. There's phagocytosis of the necrotic tissue, and when that happens, the myocardial cells that were necrotic are gradually replaced with scar tissue. Remember too that new vessel formation to support healing will go in there, but then it will then be replaced by the scar tissue. Remember that the scar tissue will not contract, it will not expand, and it will not conduct action potentials like the myocardial tissues that had been there previously or the areas around that area. The total time of healing is usually about 7 weeks. Like I mentioned before, sudden death is usually attributed to arrhythmias, and the primary arrhythmia that we look at is ventricular fibrillation. Heart failure and cardiogenic shock are associated with the extent and the location of the injury due to decreased contractility. Pericarditis occurs with patients that have large infarcts and if they also have heart failure. It can occur as early as the second or third day after the MI and for up to several months after the MI. They may be caused by autoimmune factors related to that MI. Obviously, if you've had a thromboemboli in your heart, you potentially may have a thromboemboli in other parts of your body as well. So those are considered to be complications of acute MI. Rupture of the heart occurs when there is a large amount of damaged area. It's weak, and while it's going through that healing stage, and even after the scar tissue is there, it increases the risk of rupture. Not only that, but if you have a stiff area of a ventricle, you're more likely to develop areas of weakness and develop aneurysms. And so that's why those other complications are possible. Now that we've talked about what happens with acute ischemic heart disease, let's talk about what happens with chronic ischemic heart disease. Basically, what we're looking at is an imbalance in the blood supply and the heart's oxygen demands. And we look at the causes. Do we have less blood flow to the heart? Then we might be looking at atherosclerosis or a vasospasm. Or do we have a higher oxygen demand of the muscle? For instance, if we have stress, exercise, or if we're in the cold, think about the fact that many heart attacks happen when people are shoveling snow. So they've got exercise that they're probably not used to doing on a regular basis, and they have cold acting on their heart as well. Obviously, the heart attack is an acute reaction, but they probably had this chronic ischemic heart disease all along. One of the biggest symptoms of chronic ischemic heart disease is angina. And angina is classified as chronic stable angina, which means that there's pain when the heart's oxygen demand increases, which you might expect to happen. Kind of like what we talked about, how when somebody goes out in the cold and they start shoveling snow, they'll start getting angina. That doesn't mean they're having a heart attack, but it does mean that that heart is saying that it's not getting enough oxygen. The silent myocardial ischemia is myocardial ischemia without pain. This is kind of a really scary one because if you think about it, if you're not having any angina to warn you ahead, it makes sense then that this particular group of patients would be those who end up developing STEMIs. The variant or the vasospastic angina is also associated with migraines and Raynaud's phenomena, and it's pain when the coronary arteries spasm. So if you think about it, migraines have spasming vessels up in the head. Raynaud's phenomena has spasms in the fingers. In this case, the coronary arteries themselves are spasming. It tends to occur during rest, and for some reason there's a real large correlation between it occurring between midnight and 8 a.m. So when you think about that, a lot of new graduates end up working night shifts, you're going to have a better chance of seeing patients with angina than your colleagues that are working day shift. The diagnosis of chronic ischemia is based on symptoms, risk factors, and invasive or non-invasive studies. The studies that they'll look at is like an ECG and an echocardiogram and the exercise stress test, nuclear imaging, or the CT or MRI. Those are all non-invasive studies. The exercise test is especially important because often with these patients, their resting ECG is almost always normal. But when they start to exercise, that's when we start seeing changes that are related to the ischemia that's happening in their heart. After they do these non-invasive tests, they may determine that the patient needs to have a cardiac cath and a coronary angiography. And when they do that, it's often done with the coronary cath being inserted in the femoral vein, not the artery, in the vein, and then being advanced up into the coronary arteries. There are some physicians that will use the veins in the arms to access those veins, but the most common method is the femoral vein. Treatment for chronic ischemic disease of the heart include nitrates. Again, nitrates are vasodilators. They decrease venous return with decreased ventricular volume. So if you think about it, this will lead to decreased wall pressure and decreased myocardial oxygen requirement. It may mean that their heart beats a little bit faster, but it doesn't have to beat as hard to get that blood out to the body. Beta blockers decrease the heart rate and it decreases the blood pressure. This decreases the myocardial contractility, which leads to decreased oxygen requirement. Calcium channel blockers act on both the coronary and the peripheral artery to dilate both of them. And this causes decreased myocardial metabolism. So if you think about it, if we dilate the peripheral arteries, the heart doesn't have to beat so hard in order to get the blood, the oxygenated blood out to the peripheral parts of the body. When they do a percutaneous coronary intervention, that relieves the symptoms for patients with chronic stable angina. Coronary bypass is indicated in patients with double or triple vessel disease, meaning that two or more of their coronary arteries are blocked or partially blocked. So I wanted to talk to you all at this point because your textbook in this area talks about rheumatic fever. It also talks about endocarditis. I would like you to review endocarditis, but rheumatic fever, we'll cover that in pediatrics in quite detail, and so you don't need to worry about that for this next exam. So let's move from myocardial infarctions and blood flow of the coronary arteries to valve defects. With the valve defects, if we have stenosis, it means that the valve will not open all the way. It means that blood does go through it, but it takes a lot more pressure to get it to go through it. You'll usually hear a murmur of the blood shooting through the narrow opening when the valve is open. Regurgitation is when the valve will not close all of the way. So it opened up just fine, but now it's not closing all of the way. And so when it's not closed all the way, just like our video that we watched the other day, you'll remember that it leaks when it's closed. You will hear a murmur of the blood leaking back through when the valve should be closed. The atrial-ventral valves leading into the ventricle do not work. If they don't work, then we have mitral or tricuspid problems. If the semilunar valves leading out of the ventricles don't work, then we have aortic or pulmonary problems. The left-sided valve disorders include things that happen to the mitral valve, like the mitral valve may be stenotic, or there may be regurgitation, or there may be prolapse. If there's prolapse, there's often regurgitation as well. If it's a small enough prolapse, there may not be a lot of regurgitation, and so you would not hear a murmur with it. However, if it's fairly large, then you will hear a murmur with the prolapse and the regurgitation. With the aortic valve disorders on that side, you would have aortic valve stenosis or aortic valve regurgitation. Identify if there's defective valves. The blood going through the valve makes a noise, and we call those noises murmurs. you can identify them by where they are. So in other words, as you're listening, if you remember your assessment class, the different areas that you listen on the chest is over those various valves. So where you are hearing the murmur and how that they sound, whether it's high pitched or low pitched, and when they happen, whether it's systolic or diastolic, will help to identify which valve may be involved. Chronic regurgitation results in enlarged or hypertrophied ventricles seen on the echocardiogram. And when they do Doppler flow studies, you can actually see the velocities of the blood as they go through, and you can see the regurgitation. Normally what we see is they do it in color, and so you actually will see like blue and red going through because it senses the amount of oxygen that's in the blood. And so it's really kind of a cool thing to see. If you ever have an opportunity to see an echocardiogram, definitely take that opportunity to watch them do that. As far as treatment, the management of heart failure and associated problems is the major emphasis with valvular disorders, because with that regurgitation, we're not getting the stroke volume, and ultimately with the cardiomegaly of the ventricle, especially the left ventricle, we will have more incidence of heart failure with valves. So often patients that have valvular disease over time will be started on diuretics, they'll be started on blood pressure medications, and other things that may help to avoid the heart failure. If the disease is severe, then they actually will replace the valves. And we're not going to go into all the details of how they do that and everything, but they'll do valvular replacement. Pericarditis is inflammation of the pericardium. It causes pain. It causes an exudate to be formed. The serous exudate leads to pericardial effusion, and with pericardial effusion, the patient can develop cardiac tamponade, which is the rapid accumulation of exudate, and that compresses the heart and makes it difficult for the heart to beat. The fibrous exudate leads to a friction rub and to adhesions. So in other words, the pericardium becomes adhered to the outside of the heart. It results in ECG changes. The inflammation of the pericardium may restrict the heart's movement due to the serous exudate filling up the pericardial cavity, or the fibrous scar tissue making the pericardium stick to the heart. We call that constrictive pericarditis. And the treatment is dependent on the cause, but it usually involves the administration of NSAIDs. Again, it's pericarditis. It's an inflammation, so therefore we give anti-inflammatories. So we just talked about pericarditis, and one of the major causes of pericardial effusion is pericarditis. It restricts the heart's expansion. The left ventricle cannot accept enough blood. That results in decreased cardiac output, and that results in decreased blood pressure, and ultimately it can lead to shock. The right ventricle also cannot accept enough blood, which results in increased venous pressure and jugular distension. The treatment, if it's small, is diuretics, NSAIDs, colchicine, or corticosteroids. If it's larger, then we're going to do a pericardiocentesis, where they actually put a needle into that area and pull off that fluid that's around the heart. I have seen a couple cases where they actually ended up with the equivalent of a chest tube in the pericardial area because they kept building up the pericardial effusion fluid. But that's very, very unusual to have that done. Now we'll take it to the next step. If we aren't noticing that they're having symptoms of pericardial effusion, it can lead to cardiac tamponade. Cardiac tamponade is a medical emergency. The blood or the fluid fill the space between the pericardium and the heart muscle. So the effusion in this case may not be caused by serous material. It may actually be caused because there's been trauma and there's bleeding happening inside the pericardium. The pressure prevents the heart's ventricles from expanding fully. It is the result, and it usually is the result of a penetration of the pericardium. So this is normally caused by trauma. But again, if you're not staying up on your patient that has an effusion, the same thing can happen. The lack of blood getting to the heart and the rest of the body can eventually cause shock, organ failure, and cardiac arrest. The treatment is a pericardial centesis. The symptoms include anxiety, restlessness, low blood pressure, chest pain radiating to the neck, shoulders, and back. So it sounds like they're having an MI, but that's not what's happening. They're having trouble breathing or taking deep breaths. Now, if you think back to our MI patient, they're not having trouble breathing. Although they could be rapidly breathing. The patient with cardiac tamponade will have discomfort that's relieved by sitting or leaning forward. For somebody who's having an MI, it won't matter what position they're in, they will not have their pain relieved. In addition, the person with a cardiac tamponade may have fainting, dizziness, or loss of consciousness. This loss of consciousness goes along with the fact that the blood is not getting to the heart, and so it's not getting out to the rest of the body. And in this case, it's not getting up to the brain. Your book talked about pulsus paradoxus, and this is when an abnormally large decrease in stroke volume, systolic pressure, and pulse wave amplitude happens during inspiration. The normal fall in pressure is less than 10 millimeters of mercury. When the drop is more than 10, it's referred to as pulsus paradoxus. The opposite happens during expiration, and this can be observed on the blood pressure waveform if they've got a line in. And it's defined by a drop in systolic blood pressure exceeding 10 millimeters of mercury during inspiration. And you can also see it on echocardiograms. The cardiac tamponade is a classic cause of pulsus paradoxus, but it can also be seen with patients that have a pulmonary embolus or hypovolemic shock. Cardiomyopathies are divided into primary and secondary. Primary are genetic. They're things like hypertrophic and arrhythmogenic right ventricular. Then there's mixed, or which result in dilated or restrictive cardiomyopathies. And then there's acquired, which are things like myocarditis, peripartum or Takotsubo cardiomyopathy. It means that the heart isn't going to be beating correctly. The secondary cardiomyopathies are associated with other disease conditions, like in some cases there's drugs that may cause cardiomyopathy. Diabetes and autoimmune disorders have side effects that include cardiomyopathies. Some cancer treatments and alcoholics often have cardiomyopathies as well. Hypertrophic cardiomyopathy is when there is an unexplained left ventricular hypertrophy with a disproportionate thickening of the septum and abnormal diastolic filling, cardiac arrhythmias, and left ventricular outflow obstruction. So the best way of thinking about this is, if you see this picture, the picture on the right or on the left is the normal heart, and you can see that the heart muscle on the left is pretty, it's much more muscular than the ventricle on the right side of the heart. Well, in this case, what happens is there is an outflow obstruction. So in other words, the heart is not able to push against the aortic valve and get the blood out to the rest of the body. And because of that stenosis or other cause, it makes that muscle get stronger and stronger and stronger as it's trying to push against that abnormal stenosis or other obstruction. It's often an autosomal dominant disorder, and it results in defects in contractile proteins that make the cells too weak. The cell hypertrophy has to do the same amount of work as normal cells. It needs more oxygen and it performs less efficiently, so the person is prone to heart failure and may suffer sudden death during exertion. I just wanted to briefly talk about shunts. And shunts are openings or connections that lets blood move from one side of the circulation to the other. Most of these shunts occur in the heart, and they move blood either from the left to the right or from the right to the left of the heart. Because the left side is stronger, blood is usually pushed from the left side to the right side. Shunts are perfectly normal before you're born. We have the ductus venosa, venosus that lets blood flow from the visceral veins to the vena cava and completely bypass the liver. Then we have the foramen ovale that lets blood flow from the right atrium to the left atrium and bypass the lungs. Now you might say, well, oh no, it's not getting to the lungs. Well, before you're born, you don't need your blood to get to the lungs because the lungs don't have oxygen in them. You're getting your oxygen from the placenta. The ductus arteriosus also lets blood flow from the pulmonary trunk to the aorta to bypass the lungs again. So these are normal things before you're born. After you're born, these normally close up or shrink up and go away either in the first few hours after birth or definitely by the second or third day after birth. But we're going to talk about all of these things in much more detail in PEDS. But I do want you to understand that with some people have some of these shunts, like the foramen ovale or the ductus arteriosus, that takes blood flow away from their lungs and puts it out into their bodies so that they're not as well oxygenated as they ought to be. And in some cases, because these shunts are fairly small, they don't realize that they have them until they get much, much older. And then they start having symptoms of heart failure. And then that's when they find out that they had a patent ductus arteriosus. Is what we call it, a PDA. So the bottom line on these shunts is that when it's a left to right shunt, there's less blood going to the body and more blood goes to the lungs. So yeah, the blood is oxygenated, but and the mixture has more oxygen in it, but it's repeating. It's going in a circle instead of going out to the body. With the right to left shunts, you end up with deoxygenated blood going out to the body, and there's less blood going to the lungs. So this deoxygenated blood crosses over these shunts, and then you have what we call a blue baby because the blood hasn't gone to the lungs first to become oxygenated. So this is a list of various congenital heart defects. I'm not going to make you know all these different congenital heart defects. We'll talk about them in pediatrics, and we definitely will be talking about, if I see them correctly, all of these in PEDS, and you will get to learn them next semester. So just a heads up on that. The previous picture looked at various types of heart failure and what results from them. In left-sided heart failure, we have both diastolic and systolic to look at. In diastolic, the left ventricle does not accept enough blood from the lungs. In systolic left-sided heart failure, the left ventricle does not pump enough blood to the body. So what happens is the blood backs up. And so it's in the left heart, and because it's not progressing out to the body, it starts to build up in the lungs. When it builds up in the lungs, then the right side of the heart starts getting backed up there, and then we start seeing a backup to the body as well. The body lacks blood, and the lungs fill with blood. In right-sided heart failure with the diastolic, the right ventricle does not accept enough blood from the body. So in other words, there hasn't been enough pressure to get it to go into the right ventricle. And systolic, the right ventricle does not pump enough blood to the lungs. So as the blood backs up, the right heart, it doesn't go into the right heart, so there's still a lot of blood left in the body. The left heart is not able to pump out into the body because the right side isn't taking its share from the body, which means it's going to back up again to the lungs. So the body fills with blood, but the lungs do not oxygenate enough blood. Right-sided heart failure occurs when the right ventricle has difficulty pumping blood to the lungs, and the blood backs up in the blood vessels, which causes fluid distension in the lower extremities, the abdomen, and the other vital organs. So if you think about it, this is why you end up with edema related to heart failure. So with pulmonary edema, the capillary fluid moves into the alveoli, and the lung becomes stiffer, and it's harder to inhale, and less gas exchange happens in the alveoli because there's fluid there, and you get crackles, and you'll hear crackles, and there's frothy pink sputum because they'll cough that up. And their hemoglobin does not become completely oxygenated like you would expect. Pulmonary edema is a condition where the fluid leaks into the alveolar spaces, and this can be due to hemodynamic causes like left heart failure and pulmonary venous obstructions or microvascular injury or increased capillary permeability. Clinically, we're taught to differentiate the various types of sputum. The sputum in pulmonary edema is characteristically pink and frothy. It's important to mention that the fluid that leaks into the alveolar spaces is a transudate and it's not blood. A lot of people think that that pink frothy sputum is blood-tinged sputum, but it's not. So if it was blood, we should be calling it hemoptysis, or spelled HEMOPTYSIS. And that would mean that there was blood in the sputum, but we don't have blood in the sputum. We have pink frothy sputum because it's the exudate, it's this fluid that's there. Talks about the different stages of congestive heart failure and the outlook for patients that have it. I'm going to let you go through this and review it because you can read it as well as I can, and so we'll just kind of leave it at that. There's 5 forms of shock: hypovolemic, cardiogenic, obstructive, distributive, and anaphylactic. And we're going to talk about each one of those forms of shock over the next few slides. Cardiogenic shock is when the heart fails to pump blood adequately. It results in decreased cardiac output that lowers blood pressure. The sympathetic system responds. There's vasoconstriction that increases resistance to blood flow. This increases the workload on the heart, which worsens the heart failure. Distributive or vasodilatory shock is when the blood vessels dilate and there's not enough blood to fill the circulatory system. Blood flow decreases and there's less blood returned to the heart, which means there's less blood circulated to the body. Some of the causes of distributive shock include decreased sympathetic activity, like neurogenic, if there's brain or spinal injuries, anesthetics, insulin shock, or in some cases an emotional level. Sometimes there's vasodilator substances in the blood, like the type 1 hypersensitivity anaphylactic shock and inflammatory responses to infection, like with septic shock. The vessel damage from severe, or there may be vessel damage from severe hypovolemia. Hypovolemic shock occurs when there's loss of more than 15% of the circulating blood volume. This can be a loss of whole blood, a loss of plasma, a loss of extracellular fluid, or excessive dehydration. If you think about it, some people may say, well, how do you get loss of plasma? Well, for instance, if somebody has a burn, they often aren't losing whole blood, but they're losing a lot of plasma in the oozing that's happening with that healing burn. Sympathetic vasoconstriction will mobilize blood stored in the venous side of the circulation to maintain blood returning to the heart and the brain. Compensatory mechanisms like conservation of sodium and water by the kidneys, as well as thirst, also is the body's way of trying to maintain somebody who is starting to go into hypovolemic shock. Obstructive shock occurs when there is an inability of the heart to fill properly. Usually the obstruction is to the outflow from the heart. We're going to look at Mr. M. He has heart failure. He's complaining of severe shortness of breath and has fluid in his lungs. He has tachycardia, increased diastolic blood pressure, and pale, moist skin, and he says he feels weak, dizzy, and anxious all the time. So, which side of his heart do you think is failing? I think his left side is failing. So, what will be done to treat his heart failure? Well, non-pharmacologically, we'll do some exercise training, put him on a low-sodium diet, and put him on fluid restriction and weight management. Pharmacologically, we'll give him diuretics, beta blockers, and ACE inhibitors. We may give him aldosterone antagonists or digoxin. What does DIG do? Well, DIG increases the contractility of the heart. So that's going to help the heart to be able to push the blood out to the rest of his body, right? So it won't back up into his lungs. We'll give him oxygen therapy. He may even need CPAP or BiPAP. Some of the advanced therapies that he might need, depending on how bad he is he may need a ventricular defibrillator or a cardioverter. He may even need a VAD, which is a ventricular assist device, or a heart transplant if he's gone into end-stage heart failure. I'm hoping this is a different Mr. M because now he was injured in a motorcycle accident. On arrival at the hospital, he presented with bleeding from the right leg, restlessness, pallor, sweating, elevated heart rate, weak pulse, rapid breathing, lack of bowel sounds, and his blood pressure was slightly elevated. What has happened to this patient's stroke volume? Well, we have an elevated heart rate and a weak pulse. That tells us right there that we don't have much, the stroke volume has gone down because when the heart rate goes up, it doesn't give it as much time to fill. What about the cardiac output? Well, it's probably stayed pretty much the same because with that elevated heart rate, even though it's not pumping out as much blood, it still is pumping. It's pumping out as much as it can for the rate that it's pumping at. Although the fact that he's got a weak pulse kind of tells us that the output isn't great. What's going on with the sympathetic nervous system? Well, we've got restlessness, we've got sweating, we have an elevated heart rate, we have rapid breathing. Our bowel sounds have decreased because we don't need the bowels moving and doing everything. We're in our fight or flight. So increasing our heart rate, increasing our blood pressure, increasing our respiratory rate, those are the things that we need to deal with this stress. So although he was given 6 units of blood, Mr. M got worse. He became lethargic and his blood pressure began to fall. He still had no bowel sounds or urine production. The intern ordered epinephrine and Mr. M's blood pressure increased. Well, epinephrine is an adrenergic drug. Adrenergic drugs make your blood pressure go up, right? Later, you overhear the resident telling the intern that was not the best treatment. Why not, if it raised Mr. M's blood pressure? Well, let's remember what was going on with Mr. M. He had been in a motorcycle accident and he was bleeding when he came in. So Mr. M had a problem with his volume. He had hypovolemic shock. So making his heart work harder without volume to push through was not the best thing to do. Mr. M needed some volume. Mr. M's blood pressure went up a bit. He's been moved out of the ICU. The question is, his heart says you should do a 24-hour urine collection. Why? Well, if we think back to what's been going on with him, for a while there he had acute renal failure because he wasn't having any urine output. We've also given him epinephrine. We've given him a lot of things that may affect the function of his kidneys. So we're going to watch his kidneys and look at various aspects of his kidney function. Mr. M appears to be improving. He sleeps quite a lot, but his blood pressure has remained stable. He had a little urine production, but he did not eat his supper. Checking on him in the evening, you notice that he is slightly flushed, his respiratory rate is a little high, and his temperature is elevated. What is happening to his peripheral resistance? Well, he's slightly flushed. That means that his peripheral resistance is decreased, right? Because that would mean that he had vasodilation. His respiratory rate is a little high and his temperature is elevated. What do you expect his heart rate to be like? And why? He's producing a little bit of urine, so his blood pressure is probably okay. But his temperature is elevated and he's vasodilated. So my guess is that his blood pressure would still be a little on the low side. I found this really nice chart that looks at the various types of shock. And I thought it might be a nice way for you to be able to compare and contrast the different types of shock. Have fun! Talked about earlier, anaphylaxis is really kind of a type of distributive shock. However, we tend to look at it all on its own. It is a systemic response to inflammatory mediators released in the type 1 hypersensitivity. The histamines, acetylcholine, kinins, leukotrienes, and prostaglandins all cause vasodilation. What will happen when the arterioles vasodilate throughout the entire body? Well, our blood pressure goes down the tubes. Acetylcholine, kinins, leukotrienes, and prostaglandins also can cause vasoconstriction. So, bronchoconstriction. So, what will happen when the bronchioles constrict? So, basically, what we've got is somebody with low blood pressure who can't breathe. Well, what happens with sepsis and severe sepsis? The inflammatory mediators are released into the circulation. These include the tumor necrosis factor alpha and the interleukin 1s. They cause systemic signs of infection: fever, increased respirations, respiratory alkalosis, vasodilation, and that warm, flushed skin. They also activate various pathways like the coagulation, complement, and fibrolytic pathway. They can also lead to vasodilation, which leads to decreased peripheral resistance, decreased blood pressure, and we get what we call septic shock. There is a 40% mortality for patients that go into septic shock. The inflammatory mediators also increase the metabolic rates of the tissues so that they need more oxygen at the very time when they have the least amount of blood flowing to them because of that vasodilation. So why is septic shock called distributive? Well, it's caused distributive because it is distributed, the symptoms and the effects, over the entire body. In the later phases of septic shock, blood volume decreases. Which part of the inflammatory process explains this? Think about it. The complications of shock include acute lung injury or respiratory distress syndrome. We actually call this acute respiratory distress syndrome, or ARDS. It can also result in acute kidney injury, gastrointestinal complications, disseminated intravascular coagulation, and multiple organ dysfunction syndrome. We're going to talk about a few of these. Let's go back to Mr. M. A doctor has been called in to treat him and has started him on fluids and antibiotics. You are warned by the doctor to watch that Mr. M carefully for any signs of respiratory distress. Why would blood pressure imbalances cause respiratory distress? In acute respiratory distress syndrome, exudate enters the alveoli. It blocks gas exchange and it makes inhaling more difficult. In addition, neutrophils enter the alveoli. They release inflammatory mediators and they also release proteolytic enzymes. This acts on the surfactant in the lungs, which is what keeps your alveoli open. Without that surfactant, each breath becomes more and more difficult to make. With acute kidney injury or acute renal failure, we get impaired renal perfusion caused by decreased intravascular volume. Renal vasoconstriction will actually cut off urine production, which is part of the whole acute renal failure. And continued vasoconstriction cuts off the renal oxygen supply. Without that getting returned, the renal tubular cells die, and this leads to acute tubular necrosis. Usually, this is reversible, but in some cases, there still remains some kidney involvement. All of this occurs as part of sepsis or in multi-organ failure. Disseminated intravascular coagulation, or DIC, is when the coagulation pathways have been activated. And in this case, they're activated systemically. And hence the word disseminated is all over the body. What happens then is that we get little tiny clots in many of the small blood vessels. So those clots turn into microinfarcts, which causes ischemia in many parts of the body. When all of the platelets and the clotting proteins have gotten used up, then this changes into bleeding difficulties. And so this patient that just a little while ago is clotting like there's no tomorrow, now all of a sudden is bleeding out of every orifice that there is. They will bleed from every IV stick that they had before, because as those platelets and clotting proteins are used up, then the fibrolytic enzymes start acting on those clots, and all of a sudden they're bleeding everywhere. This is a really sick patient. Multi-organ dysfunction syndrome, or MODS, is the most frequent cause of death in the non-coronary intensive care unit. Mortality rates vary from 30 to 100%. They really don't understand why it happens, just that over time each one of the organs starts shutting down. Yes, this is definitely true, because the alveoli are filled with exudate, and not blood, but the exudate that is leaked from the capillary. The surface area available for gas exchange is greatly reduced. Most of the patients will require ventilator support until the process reverses. ARDS has a huge mortality rate because it's very difficult to ventilate these patients because of the loss of surfactant. And because that is a component of ARDS that's very similar to premature babies who have respiratory distress syndrome, they actually have started giving the ARDS patients surfactant in the same way that they give premature babies surfactant. With the addition of surfactant and the respiratory support, we have more of the patients with ARDS living compared to when we started seeing ARDS show up a few years ago.